Hi, this is Elliot Fishman, and welcome to September 15th, YouTube Live, sitting in Lily's office here because my computer asked me for two-factor certification or something like that, and we couldn't get it to work. Anyway, it's great to be here. Hope everyone's doing well. It's hard to believe it's mid-September. I know people out west, it's a little bit warm. In Baltimore, it's still very nice. It's mornings are in the 60s, afternoons in the high 70s, so it's still a little bit warm. But it's kind of nice. So I hope everyone's doing well. Hope everyone's getting into the fall spirit. So that seems like should be a lot of fun. A couple of just announcements from the website. Well, one thing is we are one of the semifinalists for our app. The iQuiz app is on Mini, so we'll see what happens. Hopefully we'll win. We don't want to finish second. That's the easy thing. Second of all, we are working on a lot of new things on CTisus and on the website itself, on Facebook, on YouTube, trying to create all sorts of new content, basically getting information from you guys out there, telling us what you want, what you like. And so it's very important for us then to be able to do new things. So we are trying to do that, putting a bunch of cinematic renderings up just recently. You can see on Facebook, lots of new content on YouTube, a lot of stuff adding into the AI section, a lot of new lectures. We're posting new lectures every Monday on YouTube. And those lectures are 15 to 25 minutes. It's all new content, all lectures redone from scratch, new lectures. We're doing all sorts of things. Now, today, I think it's Oncology Month, and we're speaking about lymphoma. So I want to talk about CT evaluation of suspected lymphoma or known lymphoma or staging lymphoma. So when you do a case for lymphoma, ideally, you need IV contrast. I mean, you must have IV contrast. And oral contrast, at a minimum, you need water for good gastric and small bowel distension. And some people might say you should have positive contrast because sometimes infiltration of bowel, which occurs in lymphoma, particularly B-cell lymphoma, when it's small, can be easily missed unless you're very careful. I think if you're very careful, I think you'll do all right, particularly with IV contrast, perhaps with dual phase imaging, looking at the coronals and at times the 3D to look for any transitions, but also look for focal thickening and abnormal enhancement. If you think about staging, so we start in the neck, supraclavicular nodes, you look in the mediastinum, nodal size will vary, involvement from the anterior to middle to posterior mediastinal regions, nodes in the hilar region, subcarinal zone. Again, the extent is very variable. You can also see infiltration in the lungs, lymphangitic spread, extending from the hilum. You could also see nodules or large masses, so there's a range of appearances. When we get into the abdomen, the stomach needs to be distended because we can have involvement, particularly of B-cell lymphoma of the stomach, diffuse infiltration, more commonly in the antrum. We'll also need to look at the small bowel for processes infiltrating the small bowel, bulky masses to polypoid lesions, infiltration, obstruction, not common, but not uncommon. Remember, lymphoma can have masses which then cause intussusceptions, so that's a possibility as well. We also need to think about the mesentery, multiple nodes in the mesentery, infiltration and encasement of the vessels in the mesentery. The so-called sandwich sign is something we look at. We also look at the large bowel involvement, particularly cecum, not uncommon, tumor infiltrating the cecum and ileum, that I'm thinking about lymphoma rather than adenocarcinoma of cecum or adeno of the terminal ileum. We look for the presence of renal involvement, very much variable from unilateral to bilateral. You could have solitary masses to diffuse infiltration of the kidney only, so the kidney looks large, to infiltration of the perio-pararenal space. Bilateral involvement is more common than unilateral, but unilateral can occur. Unilateral primary lymphoma in the kidney can look like a renal cell, hypovascular mass. Perirenal involvement can look like other things from metastatic melanoma to extramedullary hematopoiesis. So possibilities in that regard. Lymphoma can involve the adrenals. It can be a solitary mass in the only site of disease, primary adrenal lymphoma. You can see large, bulky masses, unilateral or bilateral. Interestingly, with lymphoma, we talk about how they're triangular. They maintain their adrenal shape, but they can be very large. Splenic involvement. You can have primary splenic lymphoma, though most commonly there's multi-organ involvement. In the spleen, it can be diffuse enlargement with infiltration, pore enhancement. It could be solitary masses. It could be multiple masses. It could be spontaneous bleed. Similarly, in the liver, the lesions are typically hypodense. Sometimes it could be infiltrating the liver. Other times it's solitary or multiple liver lesions as well. We'll look into the pelvis for adenopathy, pelvic sidewalls, aortic bifurcation, inguinal regions. We'll look for muscle involvement. Muscle involvement is not uncommon. Bony involvement is not uncommon. Infiltration with destruction, sclerotic or lytic, extensive erosion of bone, involvement of the paraspinal regions are all things we'll look at. Again, axials and multiplanar coronals and sagittals become very important. 3D can be helpful, but most of the time it'll show better, but it may not change your staging or anything else. It's very important to use IV contrast. Without IV contrast, I think you're going to fall short in making many of the diagnoses. So again, lymphoma, primary adrenal lymphoma can be only one organ, kidney or spleen or adrenal. We may see only disease above the diaphragm or disease only below the diaphragm. You may see muscle masses. It may present as a mass which you think about metastasis and you never thought about lymphoma. Those are the things I think that CT is really good at. If you have problems, you're looking for staging. Beyond that, PET scanning is usually very good for lymphoma. High SUV is typically the case, but not always. I think CT is a great way of detecting disease. I often show cases of lymphoma in conference when I quiz the faculty because it looks like so many other things. Lymphoma, spleen and liver could look like sarcoidosis, look like metastasis, look like infection. Adrenals could look like primary ACC, can look like hyperplasia when it's small, can look like just any old solid mass of the adrenal gland. Again, kidneys, adrenal, bowel, differential diagnosis, lymphoma, metastatic disease, primary adenocarcinoma. Big nodal mass, then you're thinking of lymphoma, you got that sandwich sign, but other things give you adenopathy, Castleman's disease, testicular tumor, but lymphoma has a certain way of infiltrating that makes it more likely. I mentioned the chest, pulmonary nodules, lymphangitic spread, mediastinal adenopathy, hilar adenopathy, involvement of the chest wall, involvement of bone are all things we look at. So lymphoma is very important, as I mentioned. IV contrast, I guess, is a personal preference, oral, positive or neutral, but you need oral contrast material. So I think what I'll do is I'll stop there. Again, we are live on Facebook. We're also bringing new stuff to YouTube. We're glad people are showing up. And if you have any questions, just let me know. Monaverdi Upadhayaha, I've killed his name, I'm sure, says hi. So hi back. And again, any questions, any answers, let us know. And we thank you all for being here and have a great day. Bye, guys.